Hello and welcome, everyone. Hello, hello. We have disease prevention and reversal. We're going to be talking about statins and cholesterol today. We have with us, as always, the wonderful Dr. Megan Mescher-Cox. I will go ahead and turn it over to her in just a moment. Don't forget, if you have a question or a comment or anything you'd like to say, to pop that in the Q&A and chat, and we will definitely leave time at the end to discuss. So get your questions ready. And here is Dr. Megan Mescher-Cox.
Hi, thank you all for being here. So today we're talking about cholesterol. And it's funny because Jay and I were talking, and a lot of what is in this presentation, or at least a lot of what I wanted to put in this presentation, is very similar to what we've done in previous presentations. And it's no surprise because it's the same mechanisms that are causing high cholesterol as that's causing heart disease, as that's causing dementia, peripheral arterial disease, all of them. So when we're talking about high cholesterol, the question is, why do we care, right? They're numbers that we get on a blood test most of the time. We'll go through all the ways we can diagnose it. But at the end of the day, why do we care if the number is a little higher or a little lower at a certain time? And it really comes down to what that high cholesterol does inside our body. So we care about what it does inside our body. So most of us, high cholesterol, we worry about it because of heart disease, dementia, peripheral arterial disease. Cholesterol itself, it can build plaques inside our arteries. So start off with a bang, right? So give it to me straight, doc. How long do I have to ignore your advice? So often it seems like this from the provider perspective. I know not for many of you, because you're choosing to spend your lunch hour with us to get more advice on how to best with your health. So we talked about, yes, the high cholesterol, we worry about it not just for heart attack, which is the most common thing people think of, but also for stroke and peripheral arterial disease. We'll go over what those are. So how is it diagnosed? So nowadays, we take even a step backwards, one step more. So in the past, it was diagnosed mainly on blood tests. But nowadays, if someone were to come see a lifestyle medicine provider in the office, we're going to be asking you questions about your nutrition, your exercise, your sleep, your stress, your support system. We can tell from that information if your cholesterol is likely high. It doesn't take a blood test to give us that information. It's not perfect. Sometimes people have awful diets and their cholesterol looks wonderful. Sometimes people have wonderful diets and their cholesterol looks awful. But by far and away, from a food diary or going through a day of what someone eats, we have a really good idea of what their cholesterol levels are likely going to be. So a diet that's high in cholesterol, and actually it should more accurately in here, it should be high in cholesterol, saturated fat, and trans fats. So that's processed food. Those are animal products. So that's meat, all meat, not just red meat, but white meat and fish as well. All of them have cholesterol because they're all from a body of an animal, which is a body that produces its own cholesterol. And the dairy products. So milk, cow's milk, cheese, and eggs, and amongst others, but those are the most common. And processed plant foods. So I bolded this because we see a lot. People will switch and say, okay, I'm more plant-based, but if we're switching from an animal product to a processed plant food, even though it's a plant-based food, or at least the packaging says so, all in all, it's still processed food, and we're not going to get the benefit of eating plant-based if we're eating processed foods. Diet's low in fiber. So these go hand in hand, because if the diet is high in cholesterol, it's going to be low in fiber. If you want more information on that, we have the blog post that talks about, we're really choosing either cholesterol or fiber. Cholesterol is only found in animal-based foods. Fiber is only found in plant-based foods. So very difficult to get the both of them in one unless it's somehow processed. Lack of activity, having extra weight, so overweight or obesity, and strong family history, all being risk factors. So Also, we can find it on imaging. So let's say someone comes in for shortness of breath or abdominal pain or some other reason that we need to order an X-ray or a CT scan. On a chest X-ray like this, they'll call out if they can see calcium in the coronary arteries, because sometimes we can see that on those imaging studies. This, just to orient you all, this is a CT scan of an abdomen. So the person's laying on his back. So these are the thick back muscles back here. Here's the spine. Right in front of the spine are the blood vessels, the biggest ones that run in your body. This is the aorta. And in the aorta on here, you can see this bright white perimeter. My pathology professor always said, look where the arrows are. Like, that's how you know what you're looking at. So these arrows are pointing to this calcified plaque on the aorta. So calcified plaque, we'll get into that a little bit more in 1 second, but that's plaque that's been there long enough where it's actually calcified, like it looks like bone on imaging. The other way, so very incidentally, of course, sometimes on these imaging studies, we can find it and say, oh, okay, this person has plaque buildup already. They have atherosclerosis, and then we do blood work and see that their cholesterol is high. We can also find it from blood tests. So this 18 years and younger, there are numbers here, but we'll skip down to these. Men and women, I'm not sure why they called it out because the recommendations are the same except for this good cholesterol. So the recommended levels have been, if it's less than 125, more recently, total cholesterol, 125 to 200 being normal. More recent studies have come out that have said actually less than 150 is really where we do not see heart disease, heart attacks, and strokes from the cholesterol alone. And so less than 150 is our more stringent goal, and the goal that I always recommend to people, as does the American College of Lifestyle Medicine and more cardiologists, that we shoot for the goal of less than 150 for cholesterol levels, total cholesterol rather. Over here in this red box, we see the LDL. LDL is the low density lipoprotein. That is the bad cholesterol. The goal for that is less than 100. More stringent goal for that, again, where we do not see heart attacks or strokes from the cholesterol level, is less than 70. So less than 100 or less than 70 for the stringent. I did not highlight it here, and we'll get into a little bit of why, but about the good cholesterol. Women have higher good cholesterol than men do as far as the goal. Our estrogen levels, the natural hormone levels in females, keep that HDL, that good cholesterol, higher. So trials. So 2 trials to bring up. I won't bore you with all of the scientific medical trial information, but these are important to bring up because this is where it came, where we saw more and more stringent recommendations for the bad cholesterol, for that LDL, was beneficial. So this reversal trial, they took people that have not had a cardiac event, so people without known heart disease, and they found that when this was placed, people were placed on statins, they found that the lower that the LDL was pushed, as low as 60, they had better outcomes. So around 100, they didn't have as good of outcomes as those that were in the 60, 70 range. Prove it, this trial was people after they've had a heart attack. So medically, this is a big difference to look at these 2 different populations. And they did benefit as well from early and continued lowering of that LDL level, the bad cholesterol. So the current target level, in the past, the target level was less than 100. Now it's less than 70. Actually, closer to 50 is really where we're looking. So 50 to 70 is the agreed upon range. Okay, so this is what I'm talking about when I say HDL and LDL. If any of you have heard me use this analogy, sometimes I mess it up here, which always just makes me laugh. So, okay, so the LDL, the bad cholesterol, we'll talk about that as if it's trash because we don't want it. So LDL cholesterol is in the body and it's circulating around different spots of the body, okay? HDL, the good cholesterol, they're like the trash trucks. right? The HDL will pick up that bad cholesterol and take it back to the liver, so it will be taken care of, disposed of, degraded. So sometimes when people, I counsel people a lot, of course, any lifestyle medicine doctor does, on how do we fix things with nutrition or with lifestyle change. What we see is if we have improved nutrition, not only does LDL drop like a rock, quite often HDL, which is the good cholesterol, drops as well, and it concerns people. So this is the thing. If we don't have as much trash, we don't need as many trash trucks. So it's okay if we see the HDL go down, if the LDL goes down. That's a normal, natural phenomenon. There's no problem with it. Okay. Alternatively, in the past, we used to think, okay, really high HDL is helpful. And if my HDL is really nice and high, I don't have to worry about my high LDL. Well, that's not so much the case either, because if you have a lot of trash, even if you have more trash trucks, there's still a lot of trash circulating out there and causing harm. So hopefully that makes sense. But we don't want the LDL high, that trash level, that high for any means. So even if we have a lot of the good HDL. Okay, so another way that we can diagnose, or a better way to say it, is to risk stratify cholesterol is with the CT coronary artery calcium score. So it's a score we get, we actually put patients into a CT scanner, and we can see how much calcium buildup is on the arteries of that person's heart. So really cool test, because we're looking at that individual's anatomy. So on this, again, to orient you, so this is the breastbone, this is on the front, this is the back side of the body back here, and we're looking at the heart right here. Right here, the big circle where it says no calcium, we don't see any bright white area in that circle. So this is one of the coronary arteries going this way, and there's no calcium there. This is another one, no calcium there. So here on the right side, you can see this bright white, and that's calcium inside that coronary artery for this person. A coronary artery is the artery that supplies blood to the heart. If that artery gets abruptly blocked or chronically blocked, especially if there's any blockage in this artery, that can cause a heart attack or cause chronic chest pain from not getting enough blood flow to that heart. So if someone has that CT coronary artery calcium score done, then we can really say, okay, well, Ms. Jones, your cholesterol levels are higher than we would expect, but your calcium score is 0. So we don't see any evidence of coronary artery disease. And then we say, okay, things are good, go ahead, we'll repeat in 5 years. So the common reason to order this test is, I use it commonly, if someone is reporting that they have very good nutrition, but their cholesterol levels are quite high. There's a disconnect here. We need more information so we can know, do we really need to talk about starting a medication or becoming even more stringent with diet if there's room for that. And this is that tiebreaker test. So also, it goes the other way. Some people have low cholesterol scores, especially if they're on medications, because that can push the cholesterol lower, but there's still inflammation there in the arteries, and they can have higher amounts of coronary artery disease. So where we see moderate or extensive evidence of it, and that will tell us, no, we really need to do something now, lifestyle wise, and maybe also with medication. Goods and bads about the coronary artery calcium score. It's not covered by insurance, even though it is recommended by the American College of Cardiology and other groups of physicians. It's $150 to get the test done at the imaging center. The bad is that there is radiation involved. Okay, and this, I just like this picture because it really clarifies what we're talking about. But again, what we're worried about is not the number as much as what it might mean. And it typically means if that number is higher, that there's more plaque buildup occurring inside the arteries. So this being a normal artery, and here there's some plaque buildup, and here there's a lot of plaque buildup. So this is why I have this model out over here. So if you guys can see, so I have this model here. Okay, good. So this is a normal artery. Okay, so you can see there's a muscular ring around it. That's what helps, you know, when it's contracting or relaxing, that muscle allows it to do that. And then inside here, you can see it's pretty smooth, right? We want the inside of the artery to be very smooth. It's critical. Then things cannot get stuck. You can't have different little pimples that are formed and pop and cause downstream effects. So let me show you that. This is the one we just looked at. This is the first sign of heart disease. You see that? We call this a fatty streak. So when, let's say someone has pizza pretty often, average American has pizza once every 3 days. So average American here, having pizza, and we see fat build up in the wall of the artery. 70% of 12-year-olds have this. We already see the signs of heart disease. It progresses, it gets bigger, and then it will end up at some point very similar to our teenage years. You know, when you had acne, it'll end up forming a head and popping open. This is a very dangerous place to be because there's a lot of inflammation here in the artery, and then this can cause the downstream effects. Excuse me here, which is plaque formation. It causes this acute clot, which can then get bigger and totally close off where the blood flow needs to go, causing a heart attack, causing a stroke, causing acute blood flow stoppage to your legs. That's peripheral arterial disease, one of the ways that it shows up. And the downstream effects of not having enough blood there typically damages and kills tissue. So this next one is lipoprotein A. So we talked about how to diagnose high cholesterol. There are 2 tests that we use as those tiebreaker tests. One is that coronary artery calcium score. The other one is measuring a lipoprotein A level in your blood. So this is something that will typically be done if you have very strong family history of heart disease, or if you're still having events or your cholesterol's not coming down as much as you would expect, that type of thing. So I'll leave it simple and say that the lipoprotein A levels is genetically driven. So no matter how stringent or how clean their diet is, their lipoprotein A levels, if they're high, we're still going to have an increased risk for blood clot formation, still going to have an increased risk for high cholesterol. So this lipoprotein A level, again, we can see it, this high cholesterol on this side, and over here is how it forms more blood clots and wreaks havoc. So if people do have the high lipoprotein A levels, again, genetically driven, they have 3 to 4-fold increase of heart attacks and these other diseases here too. All-cause mortality goes up. Lipoprotein A levels, typical is less than 75, but that depends on your lab. It's not checked in everyone again, but if it's something that you think you might need, you should talk to your doctor about it. It's a simple blood test. Okay, so treatment. You all have probably seen this before if you've been on any of my talks. Ideally, the treatment would be lifestyle, right? Because that's 80% of it, and then medications and supplements, and then surgery. But nowadays, quite often, what happens is someone will end up in the ER with a heart attack or stroke, and we do the intervention first. Then they leave their own medications, and then they're left to say, okay, well, now that something's happened, let's make changes to your lifestyle. Right, it's back to that question, like, how long, doc, do I have to ignore your advice before I need to change my lifestyle? Often, and the other way that it happens is people come into our office, we see that their cholesterol is really high. A lot of us, especially in today's healthcare system, we do not have much time on the typical one-to-one visit. And so we'll say, okay, take this medication. And by the way, make sure you exercise and eat right, right? So, but really the lifestyle is absolutely critical, 80% of the equation, if not more. So I started from the top of the pyramid here and we're going down. So this is not the ideal way to treat it, but this is, again, what happens commonly. So if someone someone has an acute blockage or a chronic blockage, this is causing them issues. So this is that plaque buildup we're talking about from high cholesterol. A balloon angioplasty, they can go in with the balloon, they inflate the balloon, that opens it up, and then people can have more blood flow. This, of course, comes with risks of creating, like having that plaque break off and go downstream or bursting the blood vessel. This is also the way that they place stents. So they'll have a stent on the outside and open the stent into that area, which comes with its side effects as well. So, but this is possible in the acute phase. We do it both in the heart, in the brain, and in the legs. Surgeries. So if needed, or I should say as an option, CABG, so coronary artery bypass graft. What that is other people call open heart surgery. So let's say there's not blood flow going down these areas of the blockages at these spots. What will happen is then we'll take an artery that's coming off of this artery here, and they graft it to the heart. So instead of where that artery is going, they take it and they transpose it, sew it onto the heart here, so that your body, the heart down here can still get blood. And then this artery here, it's actually a vein. They take it from the leg and then they move it up to the heart. They sew it onto the aorta. They sew it onto the heart down here. And then that allows blood to go from that aorta down to the heart. So you can still get blood to that heart, so you have blood flow. Of course, no one wants to go through that unless they absolutely have to. So statins, since today's talk is on statins and cholesterol. Most of you have heard of statins, probably, or at least in part, because atorvastatin, it goes by the name of Lipitor, is by far the most prescribed medication ever in the United States. So atorvastatin is Lipitor, rosuvastatin is Crestor. It's off patent, so now it's reasonably priced. Those ones are the strongest of the statins. Then there's simvastatin, and you'll know all the statins because they end in statin. They work on a certain enzyme that will end up degrading more of the LDL, that bad cholesterol, at the liver. So how do they work? So what are the risks and side effects? So they do lower cholesterol levels. They absolutely do. They can lower them by over 50% even. They work in two other ways, and these are really important to know. They decrease inflammation in the arteries, and they also stabilize plaques on the walls of the arteries. So people that come in with a heart attack or with a stroke to the hospital, if they're not on a statin, even if their cholesterol level is normal, when they leave the hospital, they will be on a statin, not just for the cholesterol levels, but because of these other two mechanisms of action, the decrease in inflammation and the ability of stabilizing the plaques on the walls of the arteries. Of course, anything comes with side effects, any medication, so risks to the muscle. Some of the most common people report like muscle aches, like a deep ache, like when you have the flu. In muscle, not everyone, but it's the most common of the side effects. Can be hard on the liver. And there are studies, I know it came up in a previous webinar, but there are studies that do show that it can increase blood sugar levels if we use it at moderate or high doses. And then the examples. The other medications, just to give a nod to, there's ezetimibe, that's Zetia. It reduces the amount of cholesterol that your body absorbs from the diet. Side effects are similar on the muscles and on the liver. You add it to a statin or to a fibrate, or if someone cannot tolerate the statins because of the muscle aches usually, then oftentimes we'll do the Zetia. The PCSK9 inhibitors, these are injections once every 2 weeks or once a month. They're very potent to lower the cholesterol levels. They are newer. They have not been around very long. When we add, it's always a second line drug. So we'll add it to someone if they're on a statin at the max dose and they're not getting enough coverage, or if they cannot tolerate a statin, but they're really high risk, like they've already had a heart attack or a stroke, then we'll add these. So the medications are Repatha and Praluent. the drawbacks or the risks with them. The biggest ones are that they're extremely expensive because they're new and they're still on label. They are injections. People don't care for that. And then another big risk is the fact that they're so new. So the FDA has approved them, but we do not know the risks of long-term use with these medications yet. Also, people can have some bone pain, kind of cold or flu-like symptoms, and then injection site reaction, or they can have a severe allergic reaction with them. It's not very common, but it's something people need to know about. And then also to give a nod to fibrates and niacin. The fibrates we usually use for triglycerides in particular, if those are extremely high, and niacin to increase the HDL. And then lifestyle. So again, this is the biggest piece of the puzzle to help before there's an event or after someone has already had a cardiovascular event or has already identified that they have high cholesterol. Again, lifestyle is the biggest as far as the treatment. So as always, here's our food pyramid. So vegetables, absolutely at the core, green leafy in particular, but fruits, beans and legumes, whole grains and potatoes, nuts, seeds, avocados. Okay, so this whole pyramid from here down, 0 cholesterol. None of these foods have cholesterol. So the good thing is you're not getting cholesterol and you're not getting saturated fat. So our cholesterol numbers are going to be very low. Naturally, our LDL levels are 50 to 70. So if humans ate this way naturally, our LDLs would be 50 to 70. Sorry to Pfizer and all the other drug manufacturers, but they would not be making all this money on the statin medication. So the ones on top here to have sparingly or not at all would be the eggs, oil, fish, and then the commercially raised meats, processed foods, these kinds of things. These are very low in fiber and very high in cholesterol, saturated fat, and trans fats. So as easy as this, we follow the pyramid and our cholesterol will drop like a rock. So I love including this slide because it ties it back on it very easily. You can see that it's not an all or nothing. This is a stepwise progression. The more we have whole plant-based foods, the better the cholesterol is going to be. The better your blood pressure, the better your sugars, the lower your weight, or more normal your weight rather. Not to mention the risk for heart disease, dementia, stroke, cancers, all of that. So this is full plant-based, or as some people, it's slightly different, but some people call it vegan. So this is without any animal products. This is lacto-ovo. So that means if you have milk and eggs, this is pescatarian, so also with fish. And then this is the standard American diet. So any way we can go towards more plant foods, less of the high cholesterol foods, the lower your cholesterol is going to go. This slide is so cool because just to orient you to it, if you haven't seen it before, I'm sorry, if you've seen it before, it's important to see it again because it's that powerful. So this is Lifestyle Heart Trial. This was done, it was published in 1990. So it was done back in the 80s. The statins were not widely out yet, which is really cool because this is without any statins. Okay, so the baseline. So on this y-axis, we're looking at the diameter of stenosis, like how much plaque buildup is there in the arteries around the heart. So down here is low, that's what we want. Up here is high, we do not want that. So at this time, at the baseline, Dean Ornish did an intervention with people, but he called the Lifestyle Heart Trial. So it was on eating, so nutrition, exercise, stress reduction, and love more. So on really having support in a good community. So those 4 areas. So they did the intervention again. They started at baseline and they finished the intervention. 1 year later, they checked how much plaque was on the inside of the arteries of the heart. Again, this is without any medication. What they found was those people that were in the intervention where they had the intensive nutritional exercise, stress reduction, and love and support counseling, they had less plaque. The arteries were more open. Okay. The area or the group that did not have the intervention, which the control group, which is just people out living their life as they normally would, they had more plaque. So standard was to have more plaque, and in the intervention, they had not only maintained it and not had more plaque build up, they actually had less. So they could see in the trial that you can break down the amount of plaque that's on the walls of the arteries of the heart without drugs. What was even cooler than that was that 5 years later, between 1 year and 5 years, there was no intervention at all. The people just went to their own homes, lived their own lives. 5 years later, they were contacted and they checked the levels again. And they saw that those that had had the counseling way back when, here in the first 6 months, that they had even wider coronary arteries. So they had less plaque buildup even than they had at the 1 year mark. Whereas those in the control group, so those that did not have any of the counseling, had significantly more plaque buildup at that point. And this is a coronary artery. So this is an angiogram. This is another way to diagnose plaque buildup in the arteries. Just suffice it to say, here you can see that there's this little white area where you do not see the dye going through the vessel as much. There's some there, but not very much. After the intervention in that intensive cardiac rehab, Dean Ornish's program, the dye can more easily flow through that coronary artery. That means the blood flow has returned and you can get more blood to the remainder of the heart down here. And then weight, of course, the weight is a big piece for cholesterol, not as big as the nutrition, believe it or not, but it is a big piece. Okay, so I added in a couple questions. I wanted to make sure to leave plenty of time for questions, but the first one I was going to ask myself. So this is what we see clinically. So people will come in and they'll say, you know, doc, I went plant-based, but my numbers went up. This is what happened. And then that's when we get into the details of, okay, well, what are you actually replacing with what? Because if you're replacing salmon with an Impossible Burger or some other processed plant food, all we're doing is transitioning. Instead of having an animal-based food, we're putting in a processed food. So really important that if we're talking about going more plant-based, it's actually going more plant-based, whole food, plant-based, unprocessed. So instead of salmon, that we would have beans, for instance, or a black bean burger that's homemade, something like that. Doc, it's so hard to eat something different than my family every night. This is one that it just makes me laugh, because then I tell them laughingly, why would you do that? Save yourself, but feed everyone else the foods that you know are giving them heart disease or high cholesterol or everything, you know, that you yourself are suffering from. So we have a good laugh, and then they get that seems a little crazy, and end up slowly, sometimes fast, other times getting their family on board too.
That was absolutely fantastic. Really a lot of good information. And I know I scribbled down a bunch of questions. I know everyone has some thoughts spinning around in their brains. So let's start off with the ones that we have right off the bat. You did cover this, but we had a few people pop in a little bit later, so I think it's worth going over again. Debbie asks, having very high cholesterol, keeping plant-based diet, active physically, and sleeping well, both parents have high cholesterol. So she says, cannot take cholesterol meds because of bad reactions. What else can she do? Because they don't go down very much. They're at about 300.
I see. Okay, so if that's the case for someone, a couple things I'd recommend is one, to do one of the tests, or ask your doc to run one of the tests that are the those tiebreaker tests. So do we actually have plaque buildup? So the CT, coronary artery calcium score, that will tell us if there's plaque buildup. Check the lipoprotein A score, so then we can see if that number is really high. If the number is really high, we didn't go over this, because if there's already all these lifestyle things in place, right? You already have the great nutrition, low stress, all of that. It may be worthwhile then to talk about, do we need one of those stronger medications like the PCSK9 inhibitors, so the Repatha or the Praluent, and really have that conversation with your doc.
Great, excellent, excellent. Judith asks, size of plaque. I think what she means is particle size of cholesterol? There's been a lot more conversation about that lately. Is that something that we need to test for, or?
No, not really. I mean, sometimes we do, sometimes I do, even with patients if they're interested, but it doesn't really mean that much. Yeah, it doesn't really mean that much for the average person. I know the cardiologists around here, they specifically don't check it. The literature says don't check it. There's a lot of literature out, which is probably why people hear about it a lot. There's a lot of literature out by the people that make those fancy tests telling you that you need them. So,
or people that want to continue consuming cholesterol. So we all love to hear good news about our bad habits. So particle size hasn't been shown to be significant. What effect do the statins or Zetia have on triglycerides?
Oh yeah, so Barbara. That's good. So I kind of skipped over that, Barbara. So as far as the effect of statins and Zetia, statins will decrease the triglycerides typically. It doesn't have as big of an effect on it. The main effect is on that LDL, bad cholesterol, and also on the total. But typically they will bring down the triglycerides a bit, not as much as the fibrates directly. Zetia, same thing. It can just a little bit, but not nearly as much. If we specifically have a triglyceride problem, typically we'll reach for the fenofibrate or gemfibrozil if we need to. Statins, since they cover the more important ones, that LDL and the total cholesterol, that's what's typically our go-to if we have to have a medication.
So you talked about the difference between plaque and calcified plaque. Is it possible to reverse out from calcified plaque?
Oh, I'm so glad you asked that. Thanks. So there's plaque and there's calcified plaque, right? So plaque is like this, the actual plaque buildup here, and we worry about when it's really inflamed and it can pop open, right? So that we can reverse out of. The calcified plaque, when it calcifies, it's hard and it's back in here. So the calcified plaque, once it's formed, it will continue to be there. So as far as that calcium score, we use it to help identify to see if there's plaque that's formed, but it's not a perfect test because it can only see the calcified plaque. So if there's plaque that's been formed and has been there for some time, then it will be calcified and we'll identify it on that test. That the coronary artery calcium score will not identify the inflammatory plaque that it looks like this, and that really is what causes most of the problems. So we extrapolate that calcified plaque to make it mean, okay, yeah, for someone's been building plaque, we're assuming they're still building plaque. So if someone has calcified plaque, let's say we do a coronary artery calcium score, we see that there's tons of plaque, and then the person says, that's it, I'm going full plant-based, I'm done with this, I don't want to end up with open heart. So then if their whole lifestyle changes and they're no longer having inflammation happen inside the arteries, this doesn't happen. This happens with the inflammation. So, and theoretically it still can, right? But it's a lot lower chance if everything has calmed down in there and there's not the inflammation. In that setting, this is probably going a little too deep, but in that setting, then the calcium can actually serve to be a little bit protective because that calcified plaque holds the artery open, if that makes any sense. And then when the inflammation goes down, well, now you have this wider lumen, wider opening that the blood flow can flow through as that plaque is being worn down, the inflammatory plaque.
That's not an advocacy for creating calcified plaque in your arteries, though. So one thing that I run into quite a bit is, what about, okay, two questions from me. Prophylactic statins. How do you feel about that?
That's a good question. Medical term we use like primary intervention, secondary intervention, right? So if someone has really high cholesterol, then at certain points it's so high that we recommend a statin before they have an event, right? Ideally before they have an event. So if your cholesterol is not high and you have not had an event, there is no role for a statin. So
Right.
if we're talking about before the cholesterol levels high, you know, just maybe, let's say you have really strong family history, should you be on a statin? No, there's no rule for that, but we definitely should be really, really vigilant about the lifestyle piece of it.
So that actually leads me to my next question, and that is, so, you know, those of us in our middle years starting to think about retirement, we want to make sure that we are fit and well for retirement. Are there any sort of tests apart from cholesterol that you would recommend just to check, especially with a strong family history?
That's a good question. So the big indicators are so high cholesterol, high blood pressure, high sugar levels, diabetes or prediabetes, high weight. So if you have those diseases of excess, as they're called, as they're referred to, any of those can be an indicator that there's danger coming. If there's two or more of them, they don't just add, they're exponentially more dangerous together. So you should look at those indicators as well. If there's another test, like a stress test or something like that, not in particular. So that's sometimes in the past, we used to do it like before surgery or that type of thing. More and more, it's been getting away from that because it doesn't always indicate what's happening. The reason why it doesn't always indicate what's happening is because, again, we're looking for the inflammatory plaque, right?
Mm-hmm.
So someone can have a cardiac stress test where you get on the treadmill and you're running or walking fast rather on an incline. You can have that today. And let's say tomorrow you eat a cheeseburger for lunch and you have a lot of inflammation flowing through your bloodstream. You can have whatever plaque might be there. Maybe it was walled off yesterday, but then it popped open because of that inflammation that came from the cheeseburger. That blood can go downstream, cause a heart attack right then. So it's not, it doesn't always, you know, it gives us some information, but it doesn't mean someone is without risk. Does that make sense?
Yeah, absolutely. And that actually leads to another question I had, and that is, what are the risks of the tests? Like, I'm not talking like blood panel, I'm talking like these more advanced ones you're talking about.
Yeah, so that CT, the coronary artery calcium score, I like to order that for people. There is a risk of radiation, but that's it. There's no needle going into their body, dye flowing through their veins, nothing like that, you know, even though that radiation by itself is a risk to them. The other in the lipoprotein A, again, that's a blood test. As far as other tests that can be done on the cardiology side, specific for heart disease, that coronary artery calcium test that I talked about, they can do that with angio. So where they're injecting dye as well. There's risk with the dye. It could be hard on the kidneys and a few other things as well, but usually the kidneys is the biggest thing, along with that radiation risk. Cardiologists don't usually order that as often. They order that cardiac stress test, which is pretty, as far as risks profile. I mean, you're walking on a treadmill, so it's not bad as far as that goes, invasive wise. And if they do it with an echo, then they'll do an ultrasound too, but no radiation with that. So it's more of the cost of that. And does it actually give you the information that you're seeking to get? The other big test that I did not include in here, because it's really specific to heart disease, but an angiogram, where you're in the cardiac cath lab and doing, like, they're actually injecting dye into those arteries of your heart, or they do an angiogram for the brain or for the legs as well for peripheral arterial disease, like plaque buildup on the inside the arteries of the legs. That one can have significantly more risk with the dye in particular, not to mention the fact about if there's any intervention, then it can lead to rupture of the arteries or plaque breaking off and going downstream.
Awesome. Excellent information. Really, really fantastic. Paula just is asking if we can watch this again, as long as we have no technical difficulties. This is being recorded and it will be posted on prevdoc.com. We'll give you some links here in just a moment. Mike says, gotta run, but this was fantastic. More motivation to keep plant-based, keep away from those impossible burgers. Just really kind of limiting those processed foods is a very good idea. Any other thoughts or questions before we wrap up today? do you have any last final thoughts you want to share, Dr. Cox?
I mean, if anything, really the big thing is statins. You know, we talked about risk reduction. Statins can reduce your risk for a cardiovascular event 20 to 30%. There's definitely evidence for it. There's definitely a role for the medication. And the studies absolutely back that up. So the statins can be helpful. Risk reduction to 20 to 30%. Lifestyle risk reduction is well over 80%. So the statins, as helpful as they can be in some studies, it's a drop in the bucket compared to what we have the power to do on our day-to-day lifestyle and our day-to-day habits. So,
which is amazing. The more power we have, the more control we have over our own health. That is very, very, very good news. Very good news. Thank you, Dr. Cox. So let me just share a few details with you all. We have other resources. For those of you who are new here today, we have, we do this every first Wednesday of the month at noon. And you're welcome to check out prevdoc.com. I'll be sharing those links with you right now. There we go. So prevdoc.com is here. I'll put it in the chat as well. We have that and it has blog posts and videos from our last summit. We're going to be planning our new summit very, very soon. So watch out for details about that. Watch out for details on the events page for the webinars coming up. We list them for each month. Don't forget that Dr. Cox does Walk with the Doc the first Saturday of every month. You can have a look here at the topics that are are the theme for that day, and then go for a fabulous walk down by the beach at meganmescher-cox.com/walk with the doc. I also have Plant Chat every Saturday at 11 a.m. Pacific time. Everybody is welcome. Plant-based or plant-curious, everyone is welcome. And we typically have a topic or a theme, but most of it is just open forum discussion of challenges and triumphs and all that sort of thing, sharing of recipes. And thank you so much. Have a great rest of your day.